Tanya, Don. Yes. How are you guys?
Fine, thank you.
Good.
Good.
So, if you want to share your screen with us, that'd be great. And then I'll continue introducing you. So, I think Dawn will be more up to scratch with the latest at the research hub, but there's various different bits of research that Stephen's been involved with around Ebola and about an evaluation of the mental health units that have been set up in Sierra Leone a few years ago. As well as sort of so it's qualitative and quantitative study involved in that evaluation, and I think he's done some work on like post-Ebola syndrome, mental health outcomes, things like that. So he's going to just give us a brief overview and kind of pique people's interest about the research that he's been doing, and also about the capacity building stuff. So how the units developed over there. So that seems to be working well. Great. Okay, so over to you, Stephen. Go ahead.
Okay. Thank you, Helen, and good evening, all.
Good evening.
Yes. So, okay, today I'm going to share some of the experiences from this side in Sierra Leone at the 34 Military Hospital, which is the tertiary facility for the Joint Medical Services that provide health care to the Republic of Sierra Leone Armed Forces. So for those who may not know me, I am Stephen Sevalie. I work with the Republic of Sierra Leone Armed Forces, and at the moment I am the commanding officer of the medical services in the army. So what I am going to discuss today is to give you a brief background of generally the services we provide, but focusing each on the establishment of the research unit and how far we have come so far. So, Joint Medical Services, the word joint brings together the Army, the Navy, and the Air Force. And we have like a central medical facility that provides services to all these three wings. That is why it is called Joint Medical Services. The 34 hospital is the tertiary facility. We have a secondary facility and the equivalent of primary healthcare units distributed all over the country in every deployment. Talking specifically about research and collaboration, we established a research unit in October 2016. I think by then Helen was here as well as Hannah, working with King's Partnership Sierra Leone. Now, generally researching the environment has not been quite a popular thing. If anything, the Ebola epidemic, as bad as it was, and of course nobody ever wants it, but there are some good things that are associated with it, and that is the awareness in the environment about research and the need for collaboration. And I think some of the things we are able to take from that, especially on establishing a research unit, like about 2 years ago, is that it is a deliberate and systematic process to start with, because we do not have like research capacity in country, including at the university level. It is now that I think that is becoming gradually popular. It takes a lot of effort and deliberate thinking to push it forward. And because of the absence of the skill sets that are required to support research, it means collaboration becomes very, very important. because some of the benefits of collaboration is that you are able to ride on skill sets that you do not have in your institution or your environment. But even beyond that, some of the institutions here are not competent enough to pass the litmus test for receiving large funding, for example. However, if you collaborate with other institutions that are strong enough and credible to manage funding, then it becomes easier for you to be able to participate in like big research projects. So we have benefited from collaboration a lot. And the other key thing is that institutional leadership is very, very important. From maybe 2 points. One is that there is no way you can push forward with research if the institutional leadership does not believe in research and is not ready to support it moving forward. But the second point is that if the institutional leadership is aware, then it protects against this kind of exploitative engagement that is not uncommon in low resource settings, especially when we talk of research. Because
Can you tell us a little bit about what you mean by that, Stephen?
yes, so for example, what is common here, and I think it's happened a lot even during the Ebola epidemic, is that international institutions, they are credible, they receive funding, come into low resource setting just to whisk data away, and without a genuine motive to develop local capacity in these low resource settings. And at the end of the day, it becomes just exploitation because nobody benefits. There is no research capacity developed, and it's like people feel exploited. I think these are some of the experiences shared by Ebola survivors, even some local researchers. And if you look at the publications that came out of the last Ebola epidemic, as much as, yes, during that period, there was like an increased awareness about research and some capacity was built. But look at the authorship. I think some analysis was done, and I think about 10% will have like local authors as an insignificant position in the authorship line. But otherwise, it was mostly the locals working to collect data and give to international partners, and that is all. There is nothing to show for it. So I feel institutional leadership is very important to protect against that and ensure that in church collaboration, we are also able to develop capacity locally. So some of the work we have done, for example, through collaboration, we collaborated with University of Liverpool, and we did some work on post-Ebola syndrome. Just to set the stage straight, most of the work we do here are mostly on mental health and infectious disease, but I will just mention a few. So post-Ebola syndrome was done with University of Liverpool, and we worked with Janet Scott and Callum Semple in the University of Liverpool. Another work that was a case series of severe neurological sequelae of Ebola virus disease during the Sierra Leone epidemic. This one we work with King's Partnership Sierra Leone, and it was Patrick Howlett, that actually led this study. But it was quite a good collaboration. We worked with the local neurologists here, and 34 was also involved. I remember by then Hannah Walder was around. And besides the neurological sequelae that we found, we also screened for mental health syndrome, and about 63% of the participants had some mental health concern, suggesting that mental health issues were quite high among Ebola survivors. We have done a lot of collaboration, and I feel that that is responsible for maybe this success in establishing a research unit, as much as we are going through baby steps, but it has been sustained and the initiative is growing. For example, the viral persistence study, it was a kind of big collaboration that included WHO, the Ministry of Healthcare, US CDC and China CDC. And it was the first time that Ebola virus and its persistence in semen was like followed, and for more than 9 months, in fact, because there are some work still going on, like in Project Shield. But then it brought out this issue about sexual counseling for Ebola survival, which is something we are quite proud of. We've also done some work characterizing post-Ebola syndrome. Quite recently, we did some work with King's Partnership Sierra Leone, and on the private among healthcare workers. Thank you for being on infectious diseases, but I will just bring your attention to item number 8 on my slide here, disability among Ebola survivors. And this way also works with Liverpool. And we found that the prevalence of some form of disability or the risk of disability was higher among Ebola survivors compared to community controls. Item number 9 on my slide, psychopathology among Ebola survivors. This we have completed data collection. We have almost completed analysis and working on manuscripts. This is a work, I think, by then, Helen, you were in Sierra Leone. You may have participated a bit in collecting this data. And that is going well, but it also shows some of the benefits in collaborating. It normally creates a win-win situation in which capacity is built, the local institution gets familiar with the processes that are involved in research, but also creates the necessary motivation for young people, young doctors, to be able to channel an interest in research. Point number 10 on my slide here at the bottom, an evaluation of the rollout of decentralized nurse-led mental health unit in Sierra Leone. This is something this institution, 34 Hospital, is working closely with King's Partnership Sierra Leone. And Helen and I have been like leading this one. And what we actually did was to look at the M&E data that has been collected in country. I think I will talk a little bit more about this in the coming slides. So generally, this is in terms of practical experience on collaboration. This is what is happening here. Now, specific on mental health research, let us just see the little we have been able to do. So I just mentioned evaluation of the rollout of decentralized nurse-led mental health unit in Sierra Leone. One of the things that the Sierra Leone environment has benefited from is decentralization of mental health, and KPSL has contributed a lot to that. This decentralization took place around the Ebola epidemic, and we collected data from 2015 January to 2016 December, a period of 24 months. And we wanted to see what is the level of service uptake, what kind of diagnosis do people present with, more or less how are things going. So we went in, pulled the data together and started looking at it to see what things are looking like. So the bar chart you see here, total number of patients we provided service to over the period. These are just the age ranges, for example, 0 to 17, 18 to 24, 25 to 54. This is the way the M&E data was collected, and it was not like a designed tool that we went in to capture data. So some of the age ranges, it might not be uniform, but this is what we are able to make out of it. So we can see up to the age of 24, about 40% of our patients are below, say, 25 years of age. And another 40%, we have 43% here between 25 and 54, and 55 plus 9%. And well, the reality is some people actually do not know their age in this part of the world. If you are born in the village, you've never gone to school, your parents never went to school, at times it is a bit difficult for you to be very sure about your age. In terms of diagnosis, on the slide you can see epilepsy, stroke, seizure disorders were the most common. This is consistent really in almost all the regions in which we analyzed the data. But this is the kind of distribution we saw in terms of diagnosis. And this kind of distribution is not uncommon in places where they never had mental health services before, and you are newly introducing mental health service. Of course, in terms of accuracy of diagnosis, well, one cannot be overly sure because these are nurse-led conclusions on diagnosis. However, I think we are fairly confident because these nurses have been benefiting from quarterly training and supervision from KPSL, and they are guided by the MHGAP2, which they get regular trainings on. So this is the picture that is emerging in terms of mental health and mental health services in Sierra Leone. This other work, disability among Ebola survivors and their close contacts, was done with Liverpool, and we used the Washington Group Disability Extended Questionnaire. And what we saw was that disability was strongly associated with surviving Ebola. As you can see, 78% of Ebola survivors reported at least one form of disability versus controls that reported 11%. And this difference was significant. Well, all studies, this one has its own limitations as well, because we got Ebola survivors from the Ebola survivor database we have here, because we have an Ebola clinic, Ebola survivors clinic. So it is possible that those that present to this hospital have a higher chance of having some form of disability. But this is what we got. Some of the work that is presently ongoing is one, psychopathology among Ebola survivors. We are almost completing data analysis now. This data collection completed over a year ago. And the analysis and manuscript writing has been a bit slow. But some of the things that are emerging clearly is that psychopathology is much higher among Ebola survivors. compared to community controls. We just through collaboration as well, and this one is with Boston University 34 and Sustainable Health System, which is a local organization dedicated to research. We are looking at the impact of ADD on child development. And this one is supposed to commence in about 6 weeks from now. Implementation will commence. And we are hoping that we are also going to build capacity in this process and develop and transfer skills. So this particular study is going to consider a sample of about 1,050 in which we will capture children that were infected with Ebola. We will capture about 350 of them. We will capture children that were not directly infected, but were orphaned by Ebola, so they lost their parents to Ebola. And we will also capture children who were never infected with Ebola or who never lost a parent to Ebola. So these are like the three arms we are looking at. And yes, fine. And and we are going to see what differences will emerge. And I am also working with KPSL on facilitators and barriers to mental health service delivery. We've already collected data. This is qualitative study. Data analysis is almost complete, and we are looking at moving to manuscript writing now. In conclusion, this environment generally is taking baby steps towards developing research capacity. And in our experience, collaboration, when it is well guided, can be of tremendous value. And when the leadership is serious about research, it facilitates the process a lot. And when collaboration or the leadership is not ready to push research, it creates a lot of distrust in the environment. And that is what I have for you. Thanks for listening, and I am happy to take comments and questions.
Great, thanks for that, Stephen. That was really So if we open up the floor for questions now, if anyone's got anything they'd like to ask. I think if I just start off just by asking how plenty of people doing research, probably or wanting to do research in the future, might be wondering what the best way is to approach organisations abroad and start to build up a healthy collaborative relationship so that they can have good partnership work. What would you suggest UK organisations can do to, what's a good approach towards projects and research that might make it more collaborative and an actual genuine partnership with the Sierra Leonean organisation?
Yeah, so at the moment, the good thing is that the awareness about research, I think, is rising, and the institutional leadership have appreciated the need for research and the benefits or the mutual benefits that we can exchange. The key is that it's usually advisable, if you want to research, like in Sierra Leone, right from developing the concepts, you are able to engage the local institutions here. Of course, 34 is quite open to research, and we are really pursuing it quite strongly. The College of Medicine is also developing a lot of capacity in research now, and even the Ministry of Health has appreciated the need to pursue research. So the environment is quite friendly. to collaborate in research. And for international collaborators, I will always advise that you also want to create local ownership in the process. And it is best you begin to engage right from developing the concept so that the locals here are able to guide the process and advise what is possible and what is not possible in the environment. And also develop capacity even during developing the conceptual framework for research. Yeah.
So I was quite interested about post-Ebola.
Over to you.
Yeah, sorry, we're just having a question. I'll tell you what it is in a second. Yeah, so it's quite interesting post-Ebola syndrome, and whether it's due to kind of the physical sequelae of having had Ebola, or that it's part of the spectrum of kind of somatic symptoms and chronic fatigue. Yeah. Yep. Okay. So we had a question about post-Ebola syndrome and whether it's thought to be due to kind of the physical manifestations of the disease in the brain, I guess, or whether it's felt to be sort of somatic symptoms result of kind of the mental health impact of the disease, and what your view of that is.
Yeah. So I feel that is a question that has not been resolved. And it may be a little bit of both. So for example, in the psychopathology among Ebola survivors study, it's a case control study. But what we saw was that surviving Ebola was strongly associated with having symptoms of depression and anxiety. Headache was strongly associated with having symptoms of depression. And in fact, when Hannah was here, Hannah Walder from KPSL, we worked together, and I think Helen, you met also that going on, when a manual was developed to manage some of the symptoms of post-Ebola syndrome, because some of the headaches and joint pain were poorly responsive to analgesics, like, the NSAIDs or paracetamol or whatever. So in fact, the guide suggests that you can use things like antidepressants to manage some of the pain syndromes that are associated with post-Ebola syndrome. So the issue of a somatic disorder is possible. It is quite possible. We definitely cannot rule that out. And in fact, most of the evidence is suggesting that a psychological issue may be contributing from the early evidence we have at this stage. So I think it is an area for more research for us to be able to resolve this question.
Can I ask about the survivors?
Oh,
I'm quite struck that they're quite a research population, so I wondered what follow-up rates are, what their engagement has been over time, and I guess what the incentives are for them, just thinking about the exploitation and thinking about them as kind of this group that are quite unique, there are very few in the world, and how that relationship works. Yeah. Did you hear that, or do you want me to repeat that?
Please repeat that.
So I have a question about the cohort of survivors as a research group, what the follow-up rate of that is, what the kind of dropout rate is, and what the incentives are. Thinking about sort of what you mentioned about the potential for exploitation and
Yes, so our experience for example, my institution has been able to develop very good relationship with Ebola survivors because the military took a lead in managing most of the ETUs, or maybe the major ETUs in country during the Ebola epidemic. And yes, during the ETU, Ebola Treatment Unit. And we have an Ebola survival clinic. In fact, at the moment, we are probably the only institution that have a special clinic for Ebola survivors. So issues like dropout rates has not been a major concern for us. The compliance from Ebola survivors have been quite good. However, other research projects have been experience some form of difficulties that deals directly with Ebola Survivors Union. And this emerged, I think, at the start of the epidemic, when I mentioned about exploitative relationship. International researchers were coming in and grabbing blood specimen. Everybody was just around specimen, and what data I can get. And it is very easy for the locals who may be illiterate and, this is the first time to have Shetan experience. It is very easy for them to think that, these people, they are not interested in us. They probably, just want more of us infected and take more of our samples. So the approach is key. And even when the intent is not to exploit, but when the approach is wrong, it can easily be misunderstood and strain relationships. So I feel for anybody wanting to look at this population, the approach is important, engagement is important, and building a community of trust is quite key to moving forward. But generally, Ebola survivors are usually quite happy because they also want to understand their disease more. And they also are happy to gain the benefits that are associated with research, because some of these people are quite poor. And we normally, you provide food, you provide transportation, you give them some incentive to come to the hospital and go back. But also the medical care that they receive as a result of this research is also of tremendous value to them. So cooperation is usually quite good from my experience.
Okay, thank you, Stephen. I think that was really interesting to hear about all the different stuff that you're doing, about some of the practical ways of going about it well. So thanks for joining us. And
could you just ask in the next 5 years, what you would like to see this research centre, unit, organisation to look like?
Yeah. So I've got another final question about what you see for the research unit over the next 5 years. What's your vision? Sort of vision, yeah. Your 5-year vision for 34.
So right now I call it a research unit. In 5 years, I want that name to begin to evolve to something like a research institute. If possible, it's never wrong to be ambitious. We, at the pace we are moving now, so for example, there are a lot of other trials. For example, ZMAP, we are maintaining readiness for Ebola epidemic and developing capacity to be able to conduct research in epidemic situations in general. There is continuous quarterly training going on to conduct research in epidemic situations. There is continuous capacity building, and we are also developing the human resource now to be able to lead independent research. So we have a number of staff. Maybe at the beginning, 3-4 years back, they never had masters in research, and now we have a number of guys that have gone for 1-2 year masters training and they are coming back. We have people in field epidemiology, people in public health. We have somebody now reading biostatistics. So I imagine in 5 years' time, we will have a reasonable amount of capacity. And if we continue to engage in more and more research projects, then the institutional knowledge would have developed to such a point that we will be doing well. And that is really what I look forward to. I look forward to this research, this baby research unit becoming a very strong research institution that any international collaborator that comes to Sierra Leone will want to engage with.
Thank you. I think it's nice to not have focused on the challenges and barriers so much in this talk, which is good. Been very sort of positive, which is nice to hear. So of course there are lots of challenges and it's a low resource environment. Also it's interesting as well, isn't it, how the military can sometimes make things a little bit more, I don't know, straightforward at getting to build things like research units when you're not working with the Ministry of Health but with the Ministry of Justice. But that's the Ministry of Defence, sorry. So yeah, thanks for that, Stephen. It was really interesting. Any final questions or we'll drop out? Okay. Okay.
So hi everyone. I really don't think I've ever had a harder act to follow than someone Skyping in from Sierra Leone in military uniform with flags behind them, so I really apologise for myself. But I will try and do my very best to not be a complete disappointment following Stephen's amazing talk. I suppose he and I are two ends of the spectrum of how it's possible to do a PhD in a global mental health topic. I'm based in the UK and I'm from the UK, but my PhD is in Ethiopia. What I'll tell you a bit about is my research question and my method, so you have an idea. It's very easy to say, oh, I'm doing a PhD in global mental health, but to give you some practical reality of what it's going to involve for me, and a little bit about my kind of career journey that got me this far, because I always thought that that was interesting when I was a little bit further down the road, and then of course interrupt me at any time with any questions you might have. Stephen briefly mentioned MHGAP when he was talking about training that the staff in Sierra Leone have received in particularly identifying common mental health problems. And we did a course on MHGAP in May, which some of you might have attended. But is everyone in the room, is this the first time anyone's ever seen that or heard of that? Yeah, so just for your benefit, I'll just say it's a really practical guide that you can hold in your hand or download online for free, which I'd really encourage you to look at. It's from the World Health Organization and it's evidence-based and it's aimed at frontline primary care health providers who would not have any training in psychiatry but might routinely see symptoms of mental health problems in their clinical setting, to help them really just go through and say, right, you say your sleep isn't good, and then like look through the manual and think, what might this be? So MHGAP is a key, if you're interested in getting more involved in global mental health, a really good thing to have a look at and familiarise yourself with, because it's saying the solution to the problems of mental health around the world will not be lots of psychiatrists. We're expensive, we take ages to train, and there's a huge problem with brain drain of, psychiatrists in low and middle income countries being snapped up by the UK, which has lots of rota gaps of its own. So the solution is actually to mainstream mental health throughout healthcare, and that's the ethos behind MHGAP. So just to say what that is. But there's this this is it's a natal, antenatal, perinatal clinic in rural Ethiopia. There's this well-documented gap. The reason MHGAP is called MHGAP is that there's this gap between the burden of mental health problems in terms of symptoms and disability and disorder and stress and mortality, and what mental health care provision there is around the world. And it's largely worse in settings where you would imagine that it's very hard to keep a psychiatrist employed, so rural settings in particularly poor countries. And then thinking about what times in a person's life they ever get healthcare, there are these extreme settings like rural Ethiopia where you may never see a doctor in your whole life at all. And in countries like that, there are often things like high rates of infant mortality and maternal mortality. So really important initiatives by the World Health Organization and the United Nations, like the Sustainable Development Goals, pretty much demand low middle income countries report their maternal and infant mortality, and in so doing stipulate that the gold standard should be that women deliver their first baby in a healthcare setting, so that if they come into any difficulty in terms of obstructed labour, postpartum hemorrhage, other kinds of complications that could be rapidly fatal like sepsis, that they can have life-saving intervention and transfer to care. So it's my PhD is about perinatal mental health, and the reason in part is that this focus on the perinatal period means that your probably best chance of accessing women particularly, of them accessing healthcare will be in the perinatal period. And of course fertility rates are high, so most women have children. I think the fertility rate in Ethiopia is about 5 or 6 per woman. So one thing that really got me interested in the area of my PhD was what I saw in clinical care in the UK. Just as a trainee, I kept feeling like there was this huge recurrent experience of seeing patients and feeling that the rates of trauma that they experienced either in childhood or in their relationships now was exceptionally high. And of course it's part of psychiatry training that you take a personal history and you ask questions about a person's childhood, but I was really focused and interested in how exactly it is that trauma affects mental health, and then what we can do about that when mental health problems arise. And you might or might not have noted that there's a real resurgence of interest all around psychiatry research in childhood maltreatment. There's lots of research going on all over, including the IOP, quite a lot of biological research. It's all really interesting. But what's known to be highly prevalent also around the world, but especially in low and middle income countries, is domestic violence. And although that's widely researched by social scientists, it's quite neglected in mental health research, comparatively speaking, compared to childhood trauma. And the thing is that clearly a violent household is a violent household, so trauma can arise in a relationship, and it's likely to be either witnessed or also experienced by the child. So I felt there's this quite artificial division between childhood and adulthood trauma, and that perhaps that was an area of research that could be of interest. But I said domestic violence or intimate partner violence specifically is prevalent. The World Health Organization has recognised this. These are just averages across the different regions. Clearly, domestic violence is highly prevalent all over the world. It varies, but in some places it's more prevalent than others. It seems to have advanced the slide on its own. In Ethiopia, where my PhD is taking place, which is here, the prevalence studies they've done found prevalence of 71% of women who ever have a partner some domestic violence. So it's extremely common. It's more common than to have it than not, and so likely to be somehow relevant to women's mental health. And I mentioned the Sustainable Development Goals. They were the successors to something you might have heard of called the Millennium Development Goals, where at sort of 1999's tail end, the world powers got together and said there are some things that just aren't right, and we should make aims and use the millennium as a chance to stamp them out. So the Millennium Development Goals lasted for 15 years, and in 2015 they were reviewed and revised into something much more comprehensive called the SDGs. And they're much more comprehensive in a lot of ways, but they include things clearly that are outside of health, particularly. They're about development in all its guises. And what I think is very significant is number 5, gender equality being so highly prioritised. And hopefully everyone in the room is aware that there is a zeitgeist now of more interest and recognition of gender inequality around the world, and the prevalence of intimate partner violence does feed into this. So WHO has done a lot. You know, WHO gets criticised a lot for being sort of toothless or not really having enough money behind it, but it's done a lot of awareness raising and policy making around violence against women, and it's publicised important points like women experiencing violence are twice as likely to experience depression, 16% more likely to have low birth weight babies, so it's not just a mental health consequence, but actually physical health is affected. 1.5 times more likely to get HIV, syphilis, chlamydia or gonorrhea, all of which affect infant health too. 38% of all the murders of women globally are committed by partners, and there's also high rates of injury and alcoholism in women experiencing violence. So it's clearly what gets known as a social determinant of health. So where my PhD sits is at recognising that there's a kind of constellation of disadvantage that can occur in people who have already got a low income because they live in a low income setting. They then experience symptoms of depression or another common mental disorder, and on top of that, for various multifactorial reasons, violence is also present in their lives, and that's kind of the focus of the intersection of that is the focus of my PhD. WHO has said that there are just some kind of basic things that any woman should expect who's experiencing domestic violence from her health sector. So that could be her midwife or her GP if she has a GP, or just the health worker who comes around the village and does immunisations. Women should be able to expect women-centred care, and that's defined in the guidance. They should be asked about whether this is going on, especially when there's good reason to suspect it. Healthcare providers should be trained in how to ask and how to respond, and there should be healthcare policy and provision of services for women who would like to do something like leave their partner. Clearly, not every woman is ready to do that or wants to do that, but the provision should be there. And I guess sometimes when I had interviews for fellowships in this field, the question would be asked, is this culturally prescriptive? Like, we think domestic violence isn't okay, but maybe it's okay in a different culture, perhaps a more patriarchal society. Who are you to say what a woman should do or should expect? But I guess the ethos taken by the World Health Organization is a bit like the one that's been taken globally on female genital mutilation, that you may make cultural arguments about this, but some things are accepted and agreed universally as being basic standards of healthcare that people should expect, and that is the stance that's been taken. So these guidelines that I just went through are, this is one of the health clinics in rural Ethiopia as well. These guidelines are simple, but they're not routinely implemented at all, and probably all of you can think, have I ever had any training on domestic violence? You might have done. I think the closest you might have had is probably safeguarding training that you had to go mandatorily annually forever, but even in our setting it's not routine that we have a good pathway for domestic violence, although if you've ever had a baby I gather that we're very good at asking